Yeah, I think the biggest piece is understanding the why behind everything.
Hey team, welcome back to another episode of the Student Paramedic Podcast. Hey team, welcome back to another episode of the Student Paramedic Podcast. Today I'm sitting down with Lindsey, who is a critical care flight paramedic over in the United States, and she is well known through her Instagram page, the Prehospitalist. So she has an incredible Instagram page full of amazing content that I love looking through, so please go check it out. But today we're talking about a really cool topic, and that is when normal isn't normal. And so hopefully this can change some of your perspective and critical thinking around things, and hopefully give you a little bit of excitement to go and find out a little bit more about this topic. So thanks, Lindsey, for coming on. Would you like to introduce yourself just a little bit more before we jump into this awesome topic?
Yeah, thank you so much for having me. I currently work as a critical care flight paramedic on the East Coast of the United States. I've only been doing this for about 2 years, so I still consider myself a baby medic in the world of critical care medicine, but I have about 15 years of 911 pre-hospital experience leading up to that. In my free time, when I'm not working my full-time job, I do a lot of education for paramedic students, which is something I'm really, really passionate about. So I'm really excited to be here with you today because I know that's kind of your target audience. So thanks for having me.
That's awesome. Thank you. Well, I think we've got one of the best people to have on for this then, I guess, with your significant experience and your passion. So thank you. So what is this whole when normal isn't normal?
Yeah, I know it's kind of a vague topic. And, we were talking a little bit before the show about how I had suggested this kind of clinical topic before I realized that your content's a little more geared towards career path. But I actually think this is really, really relevant for paramedic students and new paramedics, because when we go through paramedic school, unfortunately, a lot of the education has to be black and white, because if it's not black and white, then students end up confused and they don't know what the correct answer is on testing day. So students are presented with these perfect vital sign parameters that normal should be within, and these normal presentations for shock. But when you get out in the real world, you start to find that patients kind of have their own standards, right? There's patients that have different backgrounds, different medical histories. They take different medications, and that may cause them to present a little bit differently. So sometimes when patients fall within what we call normal limits, it's not actually normal. So I have a few things bulleted out for us to talk about today that we won't take a super deep dive into any of these things clinically, but hopefully it's just a little bit of an eye-opener for paramedic students and new medics to kind of keep an eye out for some of these things that can catch us off guard.
That'll be great because, as you mentioned, we do get taught these are the parameters that everyone will sit in, and it's never the case. I don't think I've come across anyone with a textbook 120 on 80 blood pressure. So it's really interesting, and I'm really keen to go through some of these examples of when normal isn't normal. So let's jump straight into it.
Sure. So the first one I have, we'll start kind of with a simple one here, and that's decompensation through normal. What I mean by that is that I think we're all pretty familiar with how patients compensate during shock. So let's take a simple hemorrhagic shock example. You have a patient that may have internal bleeding. They start to have an increase in their heart rate. They have an increase in their respiratory rate. That's a normal compensatory response. But what we have to remember is that as these patients start to decompensate, they can no longer maintain those higher rates of compensation. So when a patient is working towards irreversible shock, that looks like a patient who is bradycardic and bradypneic and has barely palpable blood pressure. But what's between tachycardic and bradycardic? It's normal, right? So if we get to this patient we suspect that they're bleeding, their heart rate's 150, and 10 minutes into our transport, we see that their heart rate is now 90. Do we pat ourselves on the back because we fixed our hemorrhagic shock with our fluid bolus, or do we realize that this patient may be continually bleeding and is actually starting to decompensate? So that's kind of a simple hemorrhagic example. I think the same thing applies to something like a cardiogenic shock. So if we take our CHFers who, when they have that sympathetic crashing acute pulmonary edema, they present to us tachypnic and hypoxic, and they have pulmonary edema. And our goals are to reduce that afterload with nitro, right? And to help them with CPAP or BiPAP. But if they can't maintain that compensation forever. So what if we don't get to them in time? We can't get the CPAP on fast enough. We can't get them enough nitro, and they start to progress towards cardiogenic shock. Those patients who were wildly hypertensive at 180, 190, 200 systolic may now be at 120. Okay, well, are they at 120 because they miraculously fixed themselves, or are they at 120 because they are on their way down to profound hypotension from cardiogenic shock?
That's a really awesome way of putting it. I've actually never really thought of it like that before, and it's definitely something that I'm really going to think about from now on. And I think you bring up a really good point in terms of thinking about your patient more critically, having that critical thinking, instead of just sort of seeing what's in front of you. So understanding that patient pathophysiology and what could be occurring and what could have happened prior and what you're sort of expecting to see, or what you might come across later down the line. Now, I know there's a lot more. And what are some of the ones that generally get missed quite a lot?
Yes. And I would say the next one I have on my list probably fits into that category the most, which is patients who are on beta blockers and calcium channel blockers. So these meds, we know patients take for rate control for arrhythmias like AFib, and they may also take them for hypertension. So as part of that medication's job, it lowers the patient's heart rate, because in instances like AFib, if a patient's heart rate is tacking away at 180, their ventricles may not have enough time to expand and contract, and they don't get the full bang for their buck in cardiac output. So if we slow down the rate, then their heart has more of a chance to expand and contract. These drugs also tend to decrease inotropy a little bit, which in a normal healthy patient may not be a big deal. But what happens when these patients are now the ones who are bleeding out, right? And I've seen this firsthand, where I've had students or new providers say, well, I don't think that patient was bleeding out because they weren't tachy. Their heart rate was totally normal, except that it was a 65-year-old female who takes a atenolol for her AFib every day, and she can't be tachycardic, right? So we have to look in these patients at the whole big picture. We can't think that because this patient isn't perfectly tachycardic, hypotensive, tachypnic, pale, cold, clammy, they can't be hypovolemic, right? So we have to look for other signs. Is their mental status declining? Is their blood pressure declining, which is, of course, a late sign? Is their respiratory rate elevating? What does their skin look like? What does it feel like? Just because one piece of the puzzle doesn't match a textbook definition doesn't mean that patient isn't still bleeding.
And you bring up a good point there in terms of really looking at your patient. And it comes back to that, the whole notion of, don't look at the monitor and treat the monitor, treat the patient. So what would be your tips then for, making sure that you are looking at that patient, as you said, not just trying to fit every single puzzle piece together, and actually thinking critically about what's going on?
Yeah, I feel so strongly about physical assessment, and anyone that follows my page or who's been in any of my classes knows that I have a bit of an aversion to new technology. I think that a lot of the stuff that's coming out does have a place, absolutely, and it can be used well. But I think what most medics need to absolutely focus on is their hands-on physical assessment, because there is no replacement for that. I have heard more than one story of students saying, well, I couldn't get a blood pressure, so I didn't start a presser on this patient. And in my head, I'm thinking, and we have these conversations where you don't need a blood pressure to tell that a patient doesn't have good perfusion, right? Are they cold to the touch? Are they altered? Do they have a weak or barely palpable radial pulse? These things are more than enough for me to start a presser. And I had a situation like this fairly recently. We had a patient with a self-inflicted gunshot wound to the head that was decompensating, circling the drain, could not get a blood pressure on this patient, but it didn't matter, right? The patient was cold to the touch. I could barely feel a radial pulse. I need no further evidence to tell me that that patient is hypotensive and they need a vasopressor right now. So I think that just perfecting, understanding what skin tone, temperature, moisture level means. What does it mean when you feel a bounding pulse or a weak pulse? What does someone's work of breathing tell us about their condition? How do we determine work of breathing? How does their mental status play into that? I kind of like to frame it that a lot of times our numbers that we get on the monitor should confirm what we already know based on our physical assessment, right? Like we shouldn't really be surprised by a pulse ox of 75. However, I use that example, but now in COVID days, I kind of have to take that back because we have these patients who, have COVID and are up and walking with SATs of 65%. But if we take COVID out of it, right, we shouldn't really be surprised by a terrible blood pressure or a terrible pulse ox. We should already know that based on our primary assessment.
Yeah, that's a really awesome point. And yeah, you're so right. And I guess in a scenario or whatever it may be, you're practicing at uni on the mannequin, and every time you're like, okay, I got to get my blood pressure, I got to get this, I got to get that. But like at the same time, I feel like you're just going through the motions. So when on placement or when you actually get that ability to treat patients or assess patients, like utilizing them, and even though they may not need their chest auscultated, like just listen to their chest, get really familiar with every single lung sound that you can, because the more you do it, the more you're going to become obviously very familiarized with all different sounds, or what all those different pulses will feel like, or what someone who's pale and clammy looks like. So I think like you said, it definitely doesn't take away, like as in physical assessment, you can't replace it. So I feel like that's a fantastic point, and I think that needs to get across to everyone.
Yeah. And, I couldn't agree more, and especially about the lung sounds piece of that, kind of, again, talking about different levels of normal. These patients with chronic conditions have different baselines, right? So you could have a COPD patient where their normal SATs are 92% or 90%, and their lung sounds normally sound terrible, right? That could be their baseline. And, something else I wanted to mention was patients who have chronically high hypertension or chronically uncontrolled diabetes. They live at higher than normal blood pressures or blood glucoses. So particularly when we're talking about blood pressure, because identifying shock is such a profound part of our job, right? There's so many different types and causes of shock, and that's usually what precedes death in some way, shape, or form. So we shouldn't be missing it. But these patients, blood pressure tends to go up with age, right? So even if someone doesn't have wildly high blood pressure, their baseline may be 10, 20, maybe 30 points higher than a younger, healthier person. And so again, if we're sticking kind of with these same examples of the patient that is hemorrhaging or going into cardiogenic shock, what might be a quote normal blood pressure for a 40-year-old is actually a low blood pressure for a geriatric patient. So we have to keep that in mind. When you have the MVC with the elderly patient who's a little bit altered and you're not sure quite if it's just they hit their head or maybe they have dementia, but their blood pressure is, 110 systolic. we have to ask ourselves, is that low for that patient? And in a 20 something year old, we're not concerned about 110, but in an older patient, we need to think about, okay, is this actually an early sign of shock for this patient?
Fantastic. And yeah, you bring up that point of, elderly or changing dynamics in that. So how does age impact some of the things that we would see as normal? Like you said, there's blood pressure, but is there any others as well?
Oh, there's so many, right? And it depends on the patient. And there's, of course, changes with age and with blood pressure. But so much of it has to do with the medications these patients are on. And when we talk about like atypical MIs, for example, which is another kind of niche area that I feel super passionately about, there's three major categories of patients who notoriously are atypical presenters, and it's women, it's diabetics, and it's geriatrics, right? And it's for several reasons. One, we may have some neuropathy going on, especially if we have an elderly patient who's also a diabetic. But these patients are probably taking medications for pain every day, right? They might have arthritis, chronic back pain, whatever it may be, and they don't feel pain the same way as other people. So we have to be really cautious with that. I tell my students, really any complaint from head to like knees gets a 12 lead EKG, because there are some very obscure, subtle complaints that end up in MIs. But with elderly patients, I mean, even with their brain size shrinking over time, that gives them more room to bleed. So you'll have these elderly patients with subdural bleeds who had a fall a week ago, and just today it's getting to the point where there's enough blood built up in their cranium that they are starting to have a bit of an altered mental status or some symptoms. So we have to be aware of these changes with age and take them into account when we're doing our assessments.
Absolutely. And as you mentioned before, in terms of having, say, someone who's a bit hypertensive over a very long period of time, hypotension may present a little bit differently to what you would expect it to. I guess, too, that would be the same for the reverse. So people who would usually sit really low in their blood pressure or would sit really low in their heart rate, resting heart rate. I think we forget that too, because I know quite a few people that would sit at, 50 resting heart rate. And, if they had a heart rate that was, sitting 80, 90, 100, you'd be very concerned, I guess, then for them. So it's really interesting. And, yeah, I think it definitely just comes back to your assessment of that patient and sort of what's going on, what's that bigger picture. So I guess how do all of these things, if we're not thinking about that patient in the bigger picture, or we're just thinking about what the numbers look like and what we've, thought of as normal, how does this set us up for, mistakes and cognitive bias?
Yeah, I mean, and it does. And I think what I have to preface this with is that we're going to make mistakes, and we can sit here and talk about how these situations are so clear cut gray, right? Like, obviously we should know that this is obviously a gray scenario, but we all know the world does not work like that, and calls don't work like that. So I think just even having discussions like this, where we can even plant the seed in people's minds that these types of situations do exist, set people up for better success moving forward and looking at each patient as an individual. And a lot of these things are learned over time, right? You're not going to come out of paramedic school and be ready to identify all of these right off the bat. But if we can ask questions along the way as to why is this patient presenting this way, that's how we learn. And that's something I still do on a regular basis. If I have a patient and I think, this doesn't really fit the bill, like, why does this patient look like this when this is their problem? I go and investigate it, whether it's through my own research or talking with coworkers or even finding a physician in the ED to pester with my questions. I have no shame. I will find the answer. But sometimes there isn't one, right? Sometimes we just don't know, because patients are all individuals. So I think the biggest takeaway is to understand that we are going to miss things. Our goal is to not, but we will. Bottom line, period. But the way we can best address that is to ask as many questions as we possibly can of each patient presentation and try and figure out why they look the way they do.
Yeah, absolutely. And, talking about that sort of mistakes side of it, not long ago as a student, we were doing scenarios and, the scenario ended up being neurogenic shock. And so in this scenario, though, the reason why I wasn't picking it up as neurogenic shock was I was like, well, they're cool and clammy, they're not warm. That's this, picture textbook, thing that they've told us that's what neurogenic shock's going to have. That's, the I guess the differential compared to when you look at hemorrhagic shock and et cetera, et cetera. So I missed it because of that. But then I didn't think that this patient in this scenario had been outside for quite some time before they'd been found. And I was like, so I just remember that motion and I was like, wow. So when we talk about this just really gets me into the mindset of what is actually going on with this patient. They had every other sign of neurogenic shock as a potential, and yeah, just missing it because I thought that they had to be warm and pink, I guess, for that to be a thing. So, thank God that happened in a scenario, like just a practice scenario, but just really interesting because that is just ingrained in us as students to, these are your characteristics of each condition. If it meets it, it is it.
I have to laugh at that scenario as an instructor because that's mean. That's mean, because neurogenic shock as it is, I always call it the odd shock out, right? And I mean, that is one of our when normal isn't normals, right? Because we're so used to our shocky patients compensating with an increased heart rate, and these patients don't have that sympathetic stimulation. And so they're hypotensive, but there is no sympathetic compensation via pale, cool, clammy skin, unless you've been sitting out in the freezing cold, right? Or tachycardia. So that is one that can be missed as it is. And then when you mess with the textbook presentation, that really requires some critical thinking. So touche to your instructor for that one.
Yeah, look, hopefully I will never miss that ever again. But
Yeah.
but it's just
well,
funny.
I'm sorry to cut you off, but I was just thinking with with this, I don't actually know what your seasons are in your part of the world, but right now we're coming into our winter months, and I guess we're coming out of our winter months, I should say. And one of the big kind of patient populations that we've seen a lot of recently has been our inhalation injuries. We've had a lot of house fire victims. And I think this one is so important. And I think this is probably one of the most commonly encountered problems, because I can say with confidence that I have identified one isolated neurogenic shock ever in 15 years pre-hospitally, one time. And it was just luck, isolated injury, very obvious. But when it comes to CO poisoning and cyanide poisoning, those things actually are a bit more common. And one of my hatreds of pre-hospital devices is the pulse oximeter, because I think it can lie and be wrong and be slow and faulty and give us false reassurance. But these are two situations where that's a really big deal. So we know, when someone has CO poisoning or cyanide poisoning, even though it's different mechanisms at a cellular level, those patients are really hypoxic on a systemic cellular level. But our pulse ox is not going to pick up on that unless you have one of the newer ones that can measure like carboxyhemoglobin levels. But a lot of agencies still don't have those, and that's not helpful for cyanide. So I always caution students when basing treatments off of the pulse oximeter for many reasons, but especially if we're dealing with a situation like this in the winter months where someone was pulled from a house fire, from a car fire, obvious signs of smoke inhalation, we have to err on the side of caution until proven otherwise and make sure that patient is getting, full 100% FiO2 until we know that it's okay to titrate that down.
Absolutely. And you bring up a good point as well in terms of the pulse ox. And a lot of the time too, say if you've got your hemorrhagic shock patient or, your pulse ox isn't going to be reliable than either. Or if you've got someone who's really cool and clammy, you're thinking of all, you sort of older people that generally will have really cool peripheries, or, anything where they aren't necessarily perfusing well, then the peripheral oximeter is probably not going to be your best friend anyway, which is what I've found in my short time of, being a student and just a recent grad. And there are, in a hospital setting, we've got the ability to do ones on the earlobe. So it's a little bit more centralized, a little bit warmer, bit more reliable, I guess, or just certain things like that. But yeah, I think that's like that people also look on their hemorrhagic shock patient and be like, oh, they're not perfusing because the pulse ox says so. But equally, then you feel them and they're cold, clammy, weak radial pulse.
Exactly. Well, and it's like in those patients, like we already knew they weren't perfusing, right? Because they were cold and clammy, like we didn't need the pulse ox to tell us that that they didn't have enough blood circulating in their body. But it's interesting that same concept applies to even like a medical anemia, right? So those patients are not as obvious. They don't have enough red blood cells, not because they're bleeding out generally, but because of some other reason. So they may present kind of pale, short of breath, feeling weak, not feeling great. But if all the little hemoglobins they do have are fully saturated, their pulse ox is going to be like, you're doing great, right? So that's what I tell students, if someone's feeling short of breath, go ahead and put the O's on them, put a nasal cannula on. We know that's not the best option in STEMI patients or stroke patients who aren't hypoxic. But if someone is complaining of shortness of breath, then even if their pulse ox says they're okay, then I'm gonna err on the side of caution and give them a little help.
That's awesome. And so, a question too is that septic patient that we talk about. I've heard about cold sepsis, and I don't know if this relates to our within normal limits, basically. But you do have the cold septic patient that isn't, presenting with that, fever. Is that also something that comes under this topic?
Yeah, absolutely. Especially because you can have patients that start febrile and then they start to decompensate. And so, it's funny, we're doing this like when normal isn't normal, but I feel like we could also do a talk on when abnormal is normal, right? But in these patients, sometimes they don't even become febrile. Someone can be septic and never have a fever, especially in a geriatric patient. But even if they did, if they are becoming so septic that they are now transitioning to septic shock, then it's very possible that their febrile temperature is going to work its way down to hypothermic. And kind of as we talked about at the beginning, what's between hyperthermic and hypothermic? Well, it's normal, right? So when I'm worried about sepsis as a differential diagnosis, yes, temperature can be helpful. If they have the temperature of 102, okay, that's going to increase my index of suspicion, but I definitely don't need it to call a sepsis alert by any means. For those reasons, they could never be febrile. They could be on their way down from being febrile, or they could be hypothermic, and those are actually the sickest patients.
Thanks for answering that. That makes a lot of sense, and I'll really think about that going forward. Now, are there any other when normal isn't normal examples that you'd like to share?
Yeah, I think the only two I'll briefly touch on are 12 leads, which I think we kind of talked about with atypicals, but just understanding that a normal 12 lead never rules out an MI, right? So if we're worried about getting a refusal from a patient, we should never be saying, hey, I know you have chest pain, but your 12 lead looks okay, you're good, because that's not always the case, right? And then the other big one is talking about blood pressure in patients with TBIs or some other source of intracranial pressure. Because in those patients, if they have significantly increased ICP, like we're dealing with the head injury patient who is severely altered, maybe unconscious, maybe posturing, seizing, maybe pupillary changes, a quote normal blood pressure in that patient is actually going to result in profound hypoperfusion of their brain. Those patients need a much higher MAP to overcome that increased intracranial pressure and to perfuse the brain. So I won't go too much on a tangent into TBI management here, but just understanding that when patients do have ICP, and obvious signs of ICP, a quote normal blood pressure is not adequate. So this gets complicated when dealing with patients who have internal bleeding plus a TBI, but if we make it simple and deal with an isolated TBI patient, those patients are going to need fluids or vasopressors much earlier, even when their blood pressure is, 100 systolic, because that's simply not going to be adequate to overcome the ICP that they have.
That's really interesting. Yeah, fantastic to try and remember that as well. So many things to try and remember. I love it. So I guess we've talked about and touched on all of these things, and they make up, really thinking critically about the patient you've got in front of you, and being able to make decisions based off the assessment that you've come up with and using a hands-on assessment. So what to you does critical thinking and clinical decision-making mean, and how can students start to get better at it so that they are able to look at all the pieces in front of them and come up with a provisional working diagnosis?
Yeah, I think the biggest piece is understanding the why behind everything, which is exhausting because I have been investigating the why behind things my entire career, and it still results in me spending a lot of time with my nose and books and websites, right? But the why behind patient presentation, like we talked about, but also the why behind why we're doing something or why we're not doing something. Because it's very easy to go through class and to even get through orientation and memorize your protocols and memorize your pharmacology. But if you don't understand why you are or not doing something, then you truly don't have the ability to make different decisions based on different patients. So I would encourage students to really learn to do their own research, because at the end of the day, school is never going to teach you everything you need to know. Your mentor is not going to be able to teach you everything you need to know. And eventually you're not going to have any of those things anymore. And the only person you really have to rely on is yourself to go find reliable sources of information. So I caution students that just because someone has been doing this for so long, it doesn't mean they have the right answers. I encourage students to vet things that they hear, vet practices that they're seeing in the field, and ask their mentors to walk them through their thought process. Why are you doing this? Why did you decide to not give this patient nitro? Why did you decide to provide this patient with that treatment, right? And get a sense for what their thought process is, so that as a student, you can pick and choose what you like and what you don't like and apply it to your own practice.
That's really good. And that's something that's been brought up quite a bit recently in regards to sort of clinical decision making or critical thinking. And yeah, it definitely makes sense, because I don't know, I've been caught out, but when you think of things like when you ask, say, for just an example, an asthmatic patient, how many have you been ever intubated or in the ICU? I remember thinking about that, and I was like, well, why am I actually asking this? Like, now I understand, obviously, risk stratification, deterioration, where they need to go, how sick they can get. But like at the time, you just taught, okay, you need to ask these questions. And if you don't think, I guess, behind the reason behind what you're asking or what you're doing, it kind of you just go through the motions for no reason.
Yeah. Yep. I absolutely agree with that, for sure.
So I don't want to take up too much of your time, because I know you're probably very busy, so thank you for sharing your time today. Is there any other bits of advice or clinical or anything you'd like to go over with our listeners before we wrap up?
Yeah, I don't think there's any more specific clinical pearls, but I think, again, the key takeaway here is that medicine not just pre-hospital medicine, but medicine in general is never black and white. And I myself use a lot of caution when taking information from sources or people who say that something is always this way or never this way, because there is almost never and always or a never in medicine, right? Like there is just so much room for gray areas. And we just talked about, a sliver of examples today. But nothing is ever black and white. And I get students that send me scenarios all the time from calls they ran. Why did the patient look like this? Why did their EKG look like this? And I have to say, a lot of times, I don't know. I can give you a thought and a guess, but I don't know the answer. And so because of this, we're all going to make mistakes. We make mistakes at every point in our career. You're going to make mistakes as a student, as a newly certified paramedic. You're going to make mistakes after 10, 15 years of practice. And so we have to just acknowledge those and make improvements based on them. That's all we can do. Use each mistake as an opportunity to be better.
That's a fantastic way to sign it off, I think. Thank you so much. I really appreciate you coming on and sharing, your knowledge and your experience with everyone. It's really fantastic. It's what makes this podcast continue. So thank you so much. Really appreciate it. Whereabouts can everyone find you?
Yeah, I live on Instagram. So the .prehospitalist is my handle. I have a YouTube channel, but I 10 out of 10 do not recommend going to it. It's like 4 really ratchet videos in my living room with a whiteboard because I don't know how to use technology. So there's a few small topics there, but yeah, I'm on Instagram most days with new topics and quiz questions, and always happy to, answer questions via message if I have the time. So that's your best bet.
Thanks for listening to this episode of the Student Paramedic Podcast. You can connect with us on Instagram, Facebook, Twitter, or you can email us at thestudentparamedicpodcast@gmail.com.